So welcome everyone. I'm going to go ahead and get started because Paul has an action-packed presentation for us today. So it's my pleasure to introduce Dr. Paul Borghesani. I'll give you a little bit of an introduction, but I want to keep it short because I want Paul to get up here and start talking to us. So he did medical degree at MIT and was concurrently working on his PhD, which he got in neurobiology from Harvard. Then he graced us with his presence. Luckily, he came out here for residency, and then after residency did a fellowship, and then has been on faculty since. His specialty is neuroscience, functional neuroscience, and neuroimaging, and he has a great deal of research in that. And luckily for us, which I think is reflected in the topic that he's covering today, Paul shifted his focus away from some of that type of research more into education and is more focusing now on research within education. So without further ado, Paul's going to teach us about being more effective in what we do on the inpatient setting.
Thank you. So, this is a slightly different title than was on the posters, but don't worry, the content is the same, considering I didn't have any content when I put the title up on the posters. So this is very different talk for me. I've actually been doing a lot of talks in the last 3 months. Literally, can everyone hear me? Anyone hearing problem? Jeremiah, problem? Nope. I've been doing basically weekly talks for the last 3 months, mostly for teaching residents in neuroscience, but also around the area on things like acute psychosis and things that can cause psychosis, like drugs of abuse and that sort of thing. So this is the first time I've ever put this sort of talk together, and it represents some of the work I've been doing the last year, specifically with Dr. Combs and others here at Harborview to look at how to make inpatient teaching more effective. So I have no conflicts of interest whatsoever, either possible or imagined. And I would also like to state, and just to be on the record, that as I imagine many people in this room, I have never had a formal course in teaching ever in my life. And yet, if you asked me, what do I do for greater than 50% of my very well paid and respected career is teach. And it just kind of boggles my mind that that is true. So today, what I'm going to be talking about is a lot of different things, introducing a lot of different concepts in a very somewhat superficial, but hopefully interesting way to everyone so they can come away from something with something. And overall, I'm going to be talking about sort of flipped classrooms and modern learning. So all of you might have heard the term flipped classroom. It's been around for a decade or more. It's really big in higher education. We, of course, have just redesigned, not me, but the University of Washington School of Medicine has redesigned the first 2 years of medical school to really actually reflect a flipped classroom, to try to promote learner-initiated education and less sort of lecture-based learning. The flipped classroom at its very basic level is the idea that rather than coming into class and getting a nice lecture, you'd actually have a pre-recorded lecture that you would watch on your own free time and come into class and essentially in small groups or individually work with your instructors to learn something, to do something. So the bottom line is it's the idea that you wouldn't sit in class listening to a lecture. Now, the goals of that obviously is to increase the interaction with your faculty members and also to make learning more learner-centered, learner-focused, so that they're really driving what you're learning. So this is a quote that I was looking up the history of medicine, and I don't see Dr. Pershla here. I would bet money that he might recognize whose quote this is. But it is too obvious that if the sick are to reap the full benefit of recent progress in medicine, a more uniformly arduous and expensive medical education is demanded. But it is spaciously argued that improvements thus accomplished will do more harm than good, for whatever makes medical education more difficult and more costly will deplete the profession and thus deprive large numbers of all medical attention whatsoever, in order that a fortunate minority may get the best possible care. Show of hands, was this written 50 years ago, 100 years ago, or 200 years ago? 50?
Was it Holstead?
It was close, but not Holstead, no. No. Yes, Flexner. So this is a quote from his piece in The Atlantic in 1910, which was also a time that he published his overall report to the US government about the state of medical education. And in 1910, medical education generally was just medical school. Residencies were in their infancy. They are certainly developed by Osler and others at Johns Hopkins, but most folks did not go through residency at that time. So Flexner was right about one thing. Medical education has gotten very expensive. So just simple math, there are 86,000 medical students approximately across the country. The average cost of a private institution is over $50,000 a year. The average cost of a public institution is over $30,000 a year. So if you do simple math of that, there are two classes, third and fourth year medical students in the clinical years times $50,000. Basically, we're spending $2 billion a year, give or take quite a bit, on medical education. That is a big number that is going to support many different things. To put that number in context, this is the Washington state budget, and just focusing on the red and purple bars, and you can look just down the very right there, that's 2013, 2015, and these are politicians' numbers, so rather than by year, they do them by 2 years, just to confuse everyone. But the red bar that's actually Health and Human Services. So you can see approximately $12 billion a year in the state of Washington is spent on Health and Human Services. So when you talk about $2 billion a year being spent, it's getting close to states' budgets for what they're spending on overall health care, and actually is getting close to the purple line, which is overall higher education. And as you can see, the purple line wraps up about $6 billion. So about the state of Washington spends about $6 billion total on its primarily six universities that it runs. So this is a big chunk of change that's going into the education. What do you get as a medical student during the third and fourth years? Well, you get this, a nice white coat to wear usually, and hopefully you get patients that are this happy to see you. And you get permission to walk into the rooms. Basically, you're granted permission to talk to people. You also get access to this kind of a tired and fatigued resident. And then sort of educational material, which if you're opening up on your iPhone is about that size. And you can kind of read things. And then you also get access to your fine attendings who are going to teach you all their knowledge, who may or may not look like the president. So what the overall goals for today is to introduce some modern concepts in medical education, to review a survey that we did here at the University of Washington, inpatient psychiatrists that we conducted in the fall of 2015, and then also just to propose that if we actually work together, we can really improve teaching practices and our daily rounds, enhancing psychiatric education. So, you're all eating lunch, so no one's going to want to write anything, I realize. But given that we're talking about flipped classrooms and modern education practices, I would be very negligent if I didn't demand you actually participate in some of them. So, what I want you to think of is what would be the worst possible environment for learning on an inpatient psychiatric ward. And what I'm going to ask you to do is to basically think about this individually for 1 minute. Think about a few things that would make the worst possible environment on the inpatient ward. If I pose the question, what's the worst environment to propose to your significant other? I might pick the 48 bus during commuting hours when it's raining and everyone smells and the person in front of you has lice. This is all a true story, actually. So, so what is the worst possible environment? 1 minute. Take out my phone, think about it just for 1 minute. Okay, that's probably a little shy of a minute, but we'll move on. Just talk to your immediate neighbor 2 to 4 people, and decide if there's anything that we do that resembles what you just thought of as the worst possible learning environment. Just talk to your immediate neighbor. You don't have to move chairs or anything that fancy. Just talk to your neighbor. You don't want to talk. Okay, so start wrapping up. You can make a semi-decision what you think was the most sort of important things that the group talked about. And now, just 1 minute, could anyone say something we should stop doing on the inpatient unit that you think might be compromising the educational atmosphere? Does anyone? No, just out loud. Just shout it out. Anyone want to?
Bad environment.
Bad environment things that you came up with.
When it's so clinically busy, you have no time to even debrief or talk about anything.
So sort of multitasking for patients, sort of when there's so many things going on, you can't focus on one issue or one patient at a time. Other things.
Seeing the same patient who has to move to the hospital for 6 days.
Right. So actually spending time when it isn't needed. That's actually not a very good learning environment and quite frustrating at times. Okay?
Having the students watch and not get to do anything.
So that would induce coma in most people, just sort of not being able to participate and actually boredom. So that's not a good thing. So this is what you just participated in was called a TRIZ. That's the Russian of what it actually is. The translation, literal, is the theory of resolution of intervention-related tasks, whatever that means. But what TRIZ is, it's a liberating structure. And liberating structures, I would recommend you just Google search liberating structures. Is a wonderful website that lists all sorts of things you can do to promote basically interaction and problem solving, brainstorming, and new approaches to old problems. They have a nice matrix. This is the grid that they present here. Many of them are certainly, they're developed much more for the business world, but they've been applied to almost every area within society, and certainly academia is picking them up in order to facilitate what? Well, participation, mostly in class. Because if I just ask people to raise their hands, what we get is a few same people will raise their hands, we won't get new ideas. So the reason for doing liberating structures is to get everyone's ideas sort of on the floor so that we can discuss them. Some of the ones that I think, just one that I will mention, is this one right in the middle. I'll use my pointer so folks can see, is called this here, celebrity interview. What a celebrity interview is, that rather than having a guest speaker who's an expert come up here and lecture for an hour, you'd actually interview them for an hour. And I think it would be a very different lecture. And you'd have a very different content if we could really sit down and ask these experts what their opinions are on, well, what's the difference between antidepressants? Just tell us. Don't show us a big chart. What do you really think the difference is? What do you really think the most important part of CBT is? What is it? Rather than going through the intricacies of it. So anyways, liberating structures are very useful for promoting interactions. So I want to give you an example of some research in medical training. Honestly, there's not a lot of research on how to do medical rounds. I mean, depending the $2 billion we're spending per year on this, there's fantastically little research on it. So this is just an example of someone. This is Dr. Gonzalo, who at the time was at Penn State University Medical Center, who basically was a big advocate of bedside teaching. So the first thing he did is he just polled 100 or so medical students and about 50 residents, how often does bedside teaching happen during rounding? And the first thing he would report is that very few, the percentage of time was quite low, somewhere less than 30% of the time was actually spent at the bedside, and this is medical, this is sort of internal medicine rotations. And then he also just simply asked what proportion of the case presentations actually happened at the bedside. And as you can see, again, very low. Either some people said none, but a majority said that very few of the presentations actually occurred at the bedside. So Dr. Gonzalo, being a big fan of bedside education, said, I'm going to set up something to make a change. And what he did is he simply did an intervention where he gave sort of a lecture to the residents, sort of espousing the merits of bedside teaching, and then asked them in the middle of their rotations to change from doing more of the standard in the hallway rounding to more at the bedside with the patient present round. I can tell you this worked very well. Over 50% of the folks who went through the intervention said that they had a vast majority of interactions afterwards at the bedside. The attendings were also informed that they should do this. What was curious is that when he asked the residents and the medical students what changed, what was more valuable, nothing was significant. Actually, the people who went through the intervention and now were rounding at the bedside and those who were not said that basically they had the same opinions about lots of things, about the value and how knowledgeable and how skilled they were, except for this one thing that was different on their questionnaire, which is who somewhat or strongly agreed with the statement, bedside rounds are more educational for house staff and medical students. And the intervention group actually said, we're less in agreement with that statement. They actually were less in agreement that bedside rounds were important. This is actually contradictory to what we would have expected. We would expect people who had actually had the intervention who were doing it would have thought this was great. So this is a little bit of the grass is only greener kind of mentality that the control group who didn't get exposed to this was saying, I'm really missing out on something, but they're probably not. But I'll tell you who did really appreciate this, is that part of the study was also to look at what patients thought. And so the blue line is pre-intervention, how many minutes the patients thought the medical team was interacting with them. And as you can see, a vast majority of patients thought 0 to 5 minutes. I'll use my pointer here. Whereas very few thought that they were spending more time. And after the post-intervention, you can see that patients really perceived that the medical teams were spending a lot more time. They didn't necessarily understand everything that was discussed, but they just felt that they were part of the team. And 96% of the patients who were surveyed who had folks talk about their cases at the bedside wanted it to continue, thought it was a good thing. So Dr. Gonzalo points out that we did this intervention thinking that we're going to be helping students and their residents, and what really happened is it was the patients who appreciated it. So the research often kind of results in some surprising results. So what can you do to improve the overall learning on the inpatient unit? Well, there are several kind of simple techniques that I just want to introduce you to that can help. One is called the 1-minute preceptor. And the 1-minute preceptor comes from work with the 1-minute manager, which was in the early 80s, very, very popular among businesses, saying that you could do a lot in a very short period of time as long as you were focused. So the 1-minute preceptor, developed by Nair and colleagues in '92, basically gave a very simple structure that should be very familiar to anyone who's ever been through medical education, which is essentially the learner would make a statement, do a case presentation, say something, kind of make a commitment about what they know. The educator would then kind of ask them some questions about it. Then the educator would then teach some general principles, give some positive feedback on what was done right, and correct some errors. Now, if we all followed this very simple structure every interaction, it would actually be greatly beneficial, because in there is teaching, in there is feedback, both positive and more negative. The other very simple technique you can use is called SNAPS. And SNAPS just is a little bit more learner-centered and focused, which basically has the learner summarize the case or information. has a learner really talk about what the differential or what the situation is. And then it has the learner really directing their questions to the preceptor or teacher about what they would need to know. For instance, the learner might say, someone was just admitted to the hospital with depression, their TSH is 9. Do you think that's important? Is that something that I should really be following up and working up? And the preceptor can say, well, you can, but it's probably not the most important thing. You can also plan next steps and select an issue for self-directed learning. So both of these things are well researched. They have over a dozen different publications showing that they are basically easy to learn and implement. The one-handed preceptor a little bit more than SNAPS. They both really work to help the preceptor evaluate just the learner and the patient at the same time, and rather than just the patient. And it allows teaching to be targeted at the right level. They both incorporate feedback. They both promote lifelong learning and the idea that you really have to be responsible for your own learning. And they're both learner-driven. And given our emphasis on sort of flipping the classroom, both these techniques are thought of as sort of modern flipped methods. So a few factoids from psychiatric rounding. So first off, the amount of papers published on how to conduct inpatient rounds on a psychiatry unit are less than 5 throughout all of history on how to do this. There's a lot of comments about what is important to learn, but how to do it and how we might conduct it is a different question. So first off, inpatient training improves residents' comfort with severe psychopathology. That should come as no surprise. What is interesting is that there is one report saying that you simply switching the order of outpatient inpatient treatment, outpatient inpatient training reduces residents' comfort with severe psychopathology even in the 4th year of the residency. That's harder to explain. It's a little older result. But certainly kindness and communication style are mostly learned from observation and simple interactions. It's very hard to learn how to be kind and to communicate well with the patient from simply reading things in a book. So as I mentioned, some of the commonly identified goals of inpatient training are learning the psychiatric interview, the differential diagnosis and biopsychosocial formulation, treatment planning, the role of a multidisciplinary team, working with acutely ill and involuntary patients, limitations of inpatient admission. These are all commonly accepted goals of inpatient training. And I have this little guy up here thinking, because it comes back to, well, how do you do this? We all agree that this needs to be done, but no one talks. It's like kind of like a bunch of elementary or high school teachers saying, calculus is really important. We all agree calculus is important. And then walking away from the table without any sort of idea of how you're going to teach that subject. So when I was on a run once, I thought, what are the kinds of supervision that I actually received or I think are being kind of given to residents and medical students while they're on the inpatient units? So the first thing people get is clearly the shadowing role. And I chose a nice shadow with a tie because I figured it looked most like me. So shadowing is actually very effective to introduce people to what other people do. If you want to know what a doctor or what anyone does, it's actually useful to kind of walk around them for a few days. It's not really great for learning. The next type of kind of mentor is what I call the Fagin mentor from Oliver Twist. And the Fagin mentor is this very crafty individual who's going to basically take you sort of rapscallion and teach you how to become these wonderful kind of clinicians that they have all the knowledge for. That, I mean, the attending has all the knowledge and it's not written in books. And, at some point it might get you into trouble, maybe it won't, but that this is sort of secret knowledge that the attending has. The other type of attending is the Yoda attending. And I don't know about you, but every time I hear what Yoda says, he doesn't really say much or give much advice whatsoever. So this is the attending that kind of lets things happen, but doesn't really help. And the final type of attending, which I think is actually the most common, is what I call the long leash attending. And the long leash attending is like this picture here. So this woman is walking her dog who's swimming in the ocean. So let's make some assumptions about the long leash attending. I assume she loves her dog. I do. I assume she's a very law-abiding citizen and thinks she's being correct within the context of society by holding her dog on a leash. And I assume that if the dog got into trouble, she would yank the leash and save the dog's life. I also assume the dog is enjoying this. And I'll make one more final assumption. She had nothing to do with teaching the dog to swim. How many of you know what that is? That's our wow cards. I'm guilty of this. I do this. One of the times we become the long leash attending is when we take notes and allow a resident or medical student to simply do the interview without providing a lot of feedback or insight or guidance about what is going on. We can also do this in many other ways, because I do care about my residents and my medical students, but if I'm not there to give them active feedback and advice, then I'm not really teaching them much. So what we did, and here I'm using the Royal We, which is myself and Dr. Combs, we basically ran one of our inpatient faculty clinician teacher, it's not inpatient, excuse me, it's clinician teachers meeting, which includes inpatient and outpatient faculty. And we sort of did a round robin of went around and said, what are you guys doing during inpatient rounds? What kinds of things? And these are just some screenshots of what we wrote up on the board. And what came up is the general things. Some people really reinforce that students and residents should pre-round. Some reinforce that they should read papers and bring them in. Some discuss things like talks. And we made a long list of things that attendings do. From this, there was actually some immediate benefit. The first thing that was immediate was that we all sort of agreed that it was okay for your team to round without you. So some of you residents and medical students who know that sometimes the attending isn't there when you do rounds, that's actually very new here at Harborview. It's not new from a national perspective, but it's new here at Harborview. That we agreed that this was okay, that the culture that we had to be there for every minute while we did morning rounds was not really necessary. Now, we'd still have to round on patients and check in with you and all of that, but we could actually let people be a little more autonomous. The other thing is that there is no consensus for what e-materials would be practical and useful. That kind of came as somewhat of a surprise. There's so much e-materials available, so easy to do this. Why can't we have some sort of consensus on this? And then there's a general consensus that we need to promote more autonomy. This kind of gets back to point one, where we thought it was okay for people to round on their own. So, and then we, after this, we kind of sat down, created a short survey. We said, well, we want to know what people are really doing. So we didn't do this in a quantitative way whatsoever when we had the meeting. So what we did is we sent around a short survey to all the inpatient faculty asking what do they do. And these are all the questions. We don't need to go through them all. The underlying ones, these are just very common things. We ask people, do they electronically pre-round? Do they have learners present new patients? Do they have learners generate their own clinical plans? Are there opportunities for feedback? Do they use cloud-based things? So there's lots of just general questions. What are people doing? Then with the help of Joan Russo here over at Harborview, we basically made this into a nice questionnaire that used a Likert scale that basically asked attendings, what was the perceived educational value of these various things they were doing and how often they were doing them. The goals of this were, one, obviously to find out what people are doing, two, to find out what they thought was important, and three, to see if there was anything that they either were doing that they didn't think was important or they weren't doing and they thought was important. We also had some open-ended short response questions, such as we want folks to list their go-to topics. We asked if there's any resources people wanted developed. We wanted them to describe barriers to teaching. And finally, we want to describe how you keep learners engaged. So going through the results, after we got the results back, and we actually got results from 19 of 21 UW inpatient attendings, I looked them all over, and that basically you could sort of separate the responses into three groups. The first group was things that we do as inpatient attendings greater than 75% of the time, and we think is essentially essential to the inpatient experience. And none of these things come as a surprise whatsoever. We thought having folks pre-round, providing feedback in one form or another, having extended discussions about patients after we see them, and also having folks present new patients. These are all things that we were commonly doing and we thought were very important to do. Down below here, I just have the key for what these numbers mean for the proportion of for these the means and the SDs. You can see that none would equal 1 point, 2 would equal less than 25%, 3 would be about half, and 4 would be greater than 75% for proportion of learners exposed, and very similar whether something was not important, optional, fairly important, or essential for the perceived value. So the next group was, what do we do about half the time and think is fairly important? And again, none of these came as any surprise either, at least initially. So setting goals, presenting overnight events, limiting team rounds so that people could go back and talk on their own, reviewing goal attainment, attending faculty development, all these things were thought to be fairly important, and folks were doing these about half the time. What's in red here, though, are two things that came out that attendings were doing less than they essentially rated as their importance. So having learners generate their own clinical plans for patient care. Attendings were doing this about half the time overall, but they all sort of said it was essential. So there's a sort of disparity there. And finally, having learners present articles, which again was happening close to less than 25% of the time, but was also thought to be quite important to do. So these two things struck me because they're, first off, the ones that were statistically significantly different on our Likert scales, and secondly, they really reflect learner-directed activities. Finally, there were things that we do less than 25% of the time and we considered optional, things that we didn't think were very interesting. So using cloud-based learning, using standard syllabus, having team discussions about grand rounds and conferences, using other electronic things like Dropbox, all of this was infrequently used and generally thought to be optional. Again, so this was our impression of our discussion just with the Harvard Review attendings. It kind of was true across all that we had not incorporated any sort of standardized education into all of the medical school, I mean, as far as attendings go to medical school and residence. So when we look at the go-to topics, not surprisingly, psychopharmacology was frequently taught. Diagnosis and case formulation was frequently taught. Brief supportive psychotherapy was frequently taught. Lots of things. Barriers, not surprisingly, time, and time. Everyone identifies time and facts of people not being on the unit as being really detrimental to teaching. Unfortunately, some really identified lack of active learning, not showing initiative as being a problem. That there was a sense that people were not bringing the material into daily rounds. And the desired tools, I think, also reflects our questionnaire, which is in a minority of folks felt that an e-syllabus would actually be that helpful. And quite frankly, nearly half left that question blank entirely, which shows that no one really thought anything organized was going to happen, that they're going to be left on their own kind of guiding, steering the ship, and that just wasn't in our culture to think of that as an organized thing. So the takeaway points were that data gathering, presentation, discussions are alive and well in the inpatient unit. Feedback is routinely provided and felt important. There's some sentiment that learners are not presenting ideas or generating plans as much as we would like. So there's the autonomy, the flipped classroom is not happening on the inpatient units as much as we would like. And finally, standardized practices, i.e. web-based resources, are poorly utilized and felt to be sort of overall optional. So after looking at all of this and looking at what was kind of published in the literature, I sort of sat down and said, well, how could we put this all together to sort of make some recommendations for how we could improve the experience for learners on the inpatient unit? And again, when I go running, I always think about things. So I thought about a model called the 3-pass model of rounding. And essentially, it includes prepare, present, plan, assess, summarize, and self-study. Now, nothing is rocket science here. It's borrowing from a lot of other things, but it's just a mentality of getting used to how should we go about rounds on a daily basis. So what this does mean, so prepare. So yes, we would highly recommend that learners should be electronically pre-rounding, and this is happening. with the paying attention to diagnoses and medications and be aware of what's going on. Present, we definitely would encourage that learners should be responsible for presenting what's happened in the past 24 hours. You shouldn't all look at each other and wait for the attending to say what's going to happen or occur without some presentation from the learners about their understanding that they read the chart and took the salient information out. Likewise, we thought the 1-minute preceptor model, and I'll come back to this, was really very well suited for presenting new patients. Finally, plan learners should develop goals for the team assessment. So before talking to the patient, before walking to the room, we should set up a set of goals of what that daily interaction is about. If the goal is they've been on the Western waiting list for 2 months and we don't have much to talk about, that can be a goal, and you can kind of make it quick and be done. But to identify what you really want to talk about is fairly important. To assess, the assess is just we should have one learner, should be the point person for the interview. That's typically what happens, obviously, with then the attending chiming in or anyone else chiming in as time goes by. And finally, we should be using the SNAPS model to summarize that interaction to help us with our planning. So have the learner summarize the clinical situation, make recommendations and plan. And finally, we should all talk about what the self-study, what we're going to look up that day, what we're going to better ourselves by identifying things that we need to know more about. So just to kind of briefly sort of review, when we talk about using the 1-minute preceptor model to have people present patients, it is what it was developed to do. So it's hardly an adaptation, it's just using it. It's essentially just have learners present a case in some detail to 2 to 4 minutes. Then the attending would use Socratic questioning to basically fill in some gaps or answer questions that weren't presented. Teach general principles, as we said, use positive feedback, then correct errors. Just like up in the upper right-hand corner, the 1-minute preceptor sort of was designed to do. The 3-pass is a little bit more of an adaptation. I think that it actually works really well for after daily rounds, that essentially having the learners summarize the interaction, summarize what happened, summarize what the issues were, summarize what they thought the patient was saying or how their current clinical status was, then to discuss what the options could be, to really provide a basis for what you might choose for the next day of treatment, then to ask the preceptor questions such as, I'd like to choose an antipsychotic, I've thought about this, this, and this. Do you have any other thoughts or ideas of why or what you might choose? You could kind of do that. Then you can kind of plan for today's activities, and then you can select. So this sort of, again, emphasizes that we want to demand that learners are very active in their learning and sort of really take a lead on patient care. So let's pull up a little bit and just talk about generation stuff, because I kind of like this because it's like looking at a horoscope. So I'm right in the middle of the Generation X. But when I read this, I see work to live and self-reliant. That's how I was raised. And the achieve work-life balance is certainly what my major struggle is. So I look at that, I'm like, it's kind of creepy that they actually know that about me. Generation Y, according to this chart, is a little different, that they're much more to a work-life blend, socially conscious, and they learn to make a difference. The idea they really want to make a difference with their job. How do they know this stuff? This comes from a big review that's very interesting to read. They know this stuff by basically asking older and younger people to draw themselves. There's lots of questionnaires, but one of my favorite was they asked older folks and younger folks to draw themselves at both home and at work. And older folks, of course, draw themselves at home in sort of the Hawaiian shirt with a beer, throwing whatever phone they have into the toilet. You know, they don't want any part of work. And at work, of course, they're very formal. And if you look at younger folks, they draw themselves doing an identical thing. They cannot comprehend. Why would you not want to answer your work? Not emails. They wouldn't answer emails. But why wouldn't you be on texting people at work? Why would you not do that? I'm always in contact with people. So there's some differences. Also, Generation Z clearly are small. So what are some tips for facilitating your work with millennials? Because most of our residents and all you guys out there are millennials. So you have to, one tip is to introduce yourself. And I thought this is very interesting. Millennials are actually quite critical of where information is coming from. I think very skilled and recognize that marketers and conflicts of interest have really biased so much of the information you receive. They want to know who you are and what you have to really, what you're going to get out of telling them this information. So they really benefit from having a little understanding of where you came from, what your training was. Obviously, you're going to ask learners how to learn. You're obviously going to guide learning and to focus on themes, not details. It's still important to help people know where they should be looking, what level they should be looking at for information. Provide structure and clear expectations. This always kind of bewilders me. I can tell you in medical school, I never had a single real feedback session with any of my clinical instructors. And it was, I never knew what the expectations were. I just showed up and did whatever they told me. And that has just changed. And I was fine with that, but I think people are not fine with that today. Encourage collaboration. This is something else that has really been found, is that peer-to-peer collaboration in education is something that millennials and anyone who's worked in a flipped classroom really benefits from, and something I think we should really strive for to really increase. And I think some of what the chief residents have done with some of the discussion groups and getting people together has really helped that. And finally, use aesthetically appealing materials. So try to make nice looking presentations with sort of flashy things. Not that. So, so just in a liberating structure, so we don't quite have time for this, or we do have a little bit of time, but one of the other key liberating structure things is just to think about things first, discuss it with your neighbor, and basically shout it out. So if we were thinking about what sorts of things we might have learned from today's presentation, and I cut me a little slack here, we're all trying to learn something. So what kinds of things might we have learned today? Think about it for 1 minute or a little less. Turn to your nearest neighbor and simply say, what is one thing that you thought was interesting or you learned from today's lecture? And see if they say the same thing.
Yes. Sometimes they need it.
So let's just wrap it up for the sake of time. So I just want to say a show of hands. How many people think they just learned something from talking to their neighbor? Did anyone learn anything, like that their neighbor picked up something or remembered something you didn't say, or thought that something was interesting that you hadn't really thought was interesting? Did anyone have that experience? No one did? Okay. Often that happens. Okay, people are shaking their head. Often it happens that someone remembers something that was interesting, they kind of say it in a different way, and you're like, hey, you're right, that was interesting. Or I didn't understand that, but I'd like to learn more about it. So it helps just sometimes to talk about content immediately after what you've learned. Okay, so just take-home points. I think together we really can make the inpatient experience more valuable for learners. I think this is important to do. I think we have to move out of this idea that the attending is kind of all alone and kind of doing their own deal. I think I would be a big advocate of promoting more uniformity in the inpatient experience. That simple, well-described structures, the OMP, SNAPs, and of course 3PASS is a question mark because it's not simple or well-described at this point, are easy to incorporate into rounding. But I think they are. I think we should be striving to really use a model. And I don't do this. I'm guilty of not doing this because there's a lot of other pressures. But I think as a group of teachers and learners, we can strive to do this more. We can change. And then finally, remain adaptable. Interacting with colleagues is a fun and productive way to do this. I mean, this is what makes being here fun, of course. And I think interacting with your fellow attendings can really lend to improving the learning experience for everyone. So just wrapping up, a special thanks to Heidi Carmen and Jesse Markman, who helped me write the paper that's been submitted and needs to be resubmitted on this research that we've been doing as far as what's been going on the inpatient units. Joan Russo also helped us make the questionnaire. Obviously, all the inpatient attendings who completed the questionnaire, and finally, all the learners who I've worked with me over the years. I always bewilders me. I talk to a lot of attendings who work with a couple medical students a year, and I think to myself, boy, as an inpatient attending, I work between 18 and 24 medical students a year, different medical students. It's phenomenal. So I really see a lot and see a lot what happens. So thank you very much for listening. And we do have a few time for questions if there's any questions.